Auzu billahi mineşşeytanirracim. Bismillahirrahmanirrahim. Rabbi zidni ilma, Rabbi zidni ilma, Rabbi zidni ilma. Rabbi yassir ve la tuassir ve tammim bil hayr. Rabbi şrah li sadri ve yassir li amri ve ahlul uqdatan min lisani yafqahu qawli. It is the fourth part of this series of lecture regarding obstetric and gynecology. The next 10 pages start with this VVF. That means vesico-vaginal fistula. What happens in vesico-vaginal fistula? Vesico-vaginal fistula can happen after pelvic surgery, pelvic irradiation, prolonged labor, and genitourinary malignancy. For reason why genitourinary fistula or vesico-vaginal fistula may happen. It happens after pelvic surgery, pelvic irradiation, prolonged labor, or childbirth trauma, and genitourinary malignancy. Clinical feature is painless continuous urine leakage from the vagina. Continuous urine leakage from the vagina. Physical examination, dye test, and cystourethropy can be done. So dye test is important for VVF and cystourethropy can be done. Obstructed labor in resource limited area is the most common cause of VVF in the worldwide. Like in the developing countries it happens. VVF develops because excessive fetal head compression during obstetric labor, excessive fetal head compression during obstetric labor, during obstructed labor, causing injury and necrosis of the maternal vagina, rectum, and bladder. Tissue necrosis leads to erosion and the fistula and development between the proximal structure, that vesicovaginal and maybe rectovaginal, typically occurring in the first week or within the first week of postpartum. Typically occurring within the first week of postpartum. The proximity of the bladder and the vagina makes them vulnerable to fistulization. The bladder and the vaginal proximity causes the fistulization to form, and patients develop symptoms immediately following intraoperative bladder injury, cesarean delivery, or hysterectomy. Immediately following intraoperative bladder injury, like cesarean delivery and hysterectomy. Weeks or months later, following surgery, like following surgery or childbirth, like obstructed liver due to necrosis and sloughing, and years after pelvic radiography. Years after pelvic radiography, which causes progressive ischemia and breakdown. So, in time schedule, you can break it down in three parts: immediately after hysterectomy or cesarean delivery, weeks or months after due to obstructed labor, and years after due to pelvic irradiation. Because of the aberrant connection between the vagina and the bladder, patients with VVF have continuous painless vaginal discharge. They have continuous painless vaginal discharge with an abnormally elevated pH. Continuous painless vaginal discharge and abnormally elevated pH more than 4.5. Pelvic examination shows vaginal pooling of the urine, and a visible defect or an area or raised granulation tissue on the anterior wall. Bladder dye testing. This is very yield that bladder dye testing is performed to confirm the diagnosis, particularly in patients who have small fistula that are not visualized on pelvic examination. During bladder dye test, bladder is filled with dyed fluid, and patients are monitored for vaginal leakage of the dye by speculum or tampon placement. So you give dye and you wait for leakage. via speculum examination or vaginal tampon placement. Treatment is surgical repair and bladder decompression, bladder catheterization. Vaginal calf dehiscence or vaginal wound separation is a rare but serious postoperative complication after hysterectomy. After hysterectomy, vaginal calf dehiscence or vaginal wound separation happen. Although peritoneal leakage through the vagina may be seen, the apex would appear if round, indurated, or open. The next thing I want to discuss about RVF, recto-vaginal fistula. It also happens due to pelvic irritation, pelvic surgery. It can happen after colon cancer, but the most important two thing, obstetric trauma and the most atypical is Crohn's can cause RVF, uncontrollable uncontrollable passage of gas or feces from the vagina. Physical examination, fistulography, and management and MRI and endosonography. Endosonography should be done. Then rectovaginal fistula may occur after obstetric trauma, third and fourth degree perineal laceration. There is dark red velvety rectal mucosa may be seen on the posterior vaginal wall. Diagnosis is typically clinical and based on visualization of the posterior vaginal defect. For patient with an unclear presentation, imaging may be performed. Treatment is surgical repair. Then ureteral injury. Ureteral injury can occur after gynecological procedure. Hysterectomy can cause this. Vaginal calf dehiscence is a very rare complication of the hysterectomy, and ureteral injury, common complication of the hysterectomy. Common complication of the hysterectomy due to proximally due to the proximity of the ureter to the ovarian and the uterine vessel. Due to proximity of the ureter to the ovarian and the uterine vessel, patients with unilateral ureteral laceration develop a large volume of intraabdominal fluid, uroperitoneum, but typically have normal voiding, serum creatinine level, urinalysis due to functioning of the contralateral kidney and the ureter. As the urine continuously fill the abdomen, it can overflow through the vaginal apex and result in watery vaginal discharge. The caustic effect of the urine may cause signs of the peritoneal inflammation, fever, nausea, and abdominal pain. Diagnosis is typically by CT ureterography, and treatment is surgical repair. So ureteral injury can happen after hysterectomy. You can get the watery vaginal discharge, and the urine causes the peritoneum to cause inflammation, and thus fever, nausea, abdominal pain happen. CT urography should be done for diagnosis of the ureteral injury, and surgical repair is the treatment. Then cervix. In the cervix, to see colpo means vagina and scope means to look at. Mm, Colposcopy, which provides an illuminated and magnified view of the vulva, vagina, and the cervix, can identify the precancerous lesions. CIN. It is performed in patients with abdominal cervical cancer screening, abnormal cervical cancer screening. In abnormal cervical cancer screening, colposcopy should be done. However, patients with unsatisfactory colposcopy, scomocolumnar junction not completely visualized, and high likelihood of the cervical dysplasia required endocervical curettage. If colposcopy is if colposcopy doesn't give you the answer, you should do endocervical curative sampling of the endocervical canal to fully evaluate the cervix for lesion. In the patient colposcopy with ectocervical biopsy, shown CN1. However, the results were unsatisfactory because the scomocolumnar junction was not completely visualized. Therefore, endocervical curettage was performed. To see these revealed CN3 high risk precancerous lesion with 15 to 40% risk of progression of invasive cancer. CIN is also significant. CIN is also a significant risk factor for concurrent invasive cervical cancer. Therefore, treatment of CIN3, whether in the endo or the ecto, uh, is with immediate cervical conization. Therefore, treatment of CIN3 is with immediate cervical conization. Cervical conization is both diagnostic and therapeutic procedure, removal the entire lesion and allowing the examination of the full depth of the lesion. Cervical conization is the process in which it is both diagnostic and therapeutic, typically removing the entire lesion and allowing for examination of full depth of invasion. All the non-pregnant patients, all the non-pregnant patients aged more than 25 with CN3 require excision of the transformation zone cone biopsy due to high risk of progression to invasive squamous cell carcinoma. In high-grade high-grade squamous intraepithelial lesion on pap testing are concerned for underlying severe neoplasia CN2 and CN3 or invasive cervical cancer. All the patients all the patients and even pregnant women require immediate colposcopy. Endocervical curettage is an invasive procedure and deferred during pregnancy due to risk of miscarriage and preterm delivery. Cervical biopsy is performed even in pregnancy uh, if a lesion has high-grade feature. Endocervical curettage is not done during pregnancy due to risk of miscarriage and delivery. Cervical biopsy can be done in high-risk cases. HPV co-testing is used to triage atypical squamous cell of undetermined significance and low-grade intraepithelial lesion. Pap test further evaluation with colposcopy is indicated if high-risk HPV is present. Now, CIN, cervical intraepithelial neoplasia. Colposcopy is the gold standard method for diagnosing CN. CN3 is a pre-malignant cervical lesion at high risk of progressing to squamous cell carcinoma and cervical conization. Cervical conization, excision of the intake, excision of the intake transformation zone is recommended for treatment. Cervical conization may be performed with scalpel, cold knife conization, or by electrocautery as known as LEEP, loop electrosurgical excision procedure. Loop electrosurgical excision procedure. CIN cervical conization. may be performed with scalpel or via electrocautery as known as loop loop electrosurgical excision procedure LEEP. Cervical stenosis, an abnormal stricture of the cervical canal, is a potential complication of the cervical colonization due to scar tissue. Cervical stenosis may impede menstrual flow and cause secondary dysmenorrhea and amenorrhea. The obstruction of the cervical outlet to prevent sperm entry and resulting in impaired fertility. Now, cervical colonization. What happens in cervical colonization? Indication is cervical intraepithelial neoplasia grade 2 and 3. The complication of cervical colonization, cervical stenosis, preterm birth, preterm premature rupture of the membrane, and second trimester pregnancy loss. So in cervical colonization, we actually it is indicated for CN2 and CN3, and complication is cervical stenosis, preterm birth, preterm premature rupture of the membrane, and second trimester pregnancy loss. Management of CN3, not currently pregnant, loop electrosurgical, loop electrosurgical excision procedure, cold knife colonization, and cryoablation can be done. PAP testing with HPV co-testing 1 to 2 years after post-procedure. This is the management of CIN3. So for CIN3, loop electrosurgical excision procedure, cryoablation, cold knife colonization should be done. PAP testing with HPV co-testing 1 to 2 hours after the post-procedure. This is normal cervix. This is low grade, less than 1/3 of the epithelium is involved. This is side. This is high grade, more than 1/3 of the epithelium is involved. And cervical carcinoma. Cervical carcinoma through basement invasive through basement membrane. Patient with CIN3 require cervical conization. Patient with CIN3 require cervical conization, which is a diagnostic and both therapeutic procedure. The excision specimen The excision specimen should be assessed for the depth of the invasion and the surgical margin, whether all the dysplasia were removed or not. In patient without invasive cancer, management is based on the surgical margin. Patient with positive surgical margin and have residual cervical dysplasia that progress to cancer. Therefore, these patients require additional surgical excision or either repeat conization if the fertility is desired, or hysterectomy if no fertility is done. So after cervical colonization, if we found that there is still cervical dysplasia is present, so you should do again to colonization, or if the patient wants to pregnant, if the patient does not want to pregnant, a hysterectomy should be done. In contrast, negative surgical margin have no evidence of residual dysplasia because these patients have persistent HPV infection that has caused prior high-grade disease, and they are high risk of recurrent cervical dysplasia and cancer. Therefore, these patients require negative surgical margin. Patient with negative surgical margin, they should be under frequent cervical cancer screening with PAP and HPV coexisting 1 to 3 years of the post procedure. That is a very important talk. That is a very important talk. This is the picture of the normal cervical PAP test. Pap smear. Pap smear results requiring endometrial evolution. This is the normal cervical. This is a normal cervical pap test. This is squamous cell line to cervix. This is the squamous cell line to cervix. In here there is abundant neoplasm. Abundant neoplasm. Okay. Benign appearing endometrial cell, premenopausal abnormal uterine bleeding, or risk for endometrial hyperplasia, and for postmenopausal women. Group requiring endometrial sampling, premenopausal women with abnormal uterine bleeding or risk for endometrial hyperplasia, and postmenopausal women. If there is atypical glandular cell, in this case you require endometrial evaluation. Atypical glandular cell with woman age more than 35 or risk of endometrial hyperplasia. And atypical glandular cell favor neoplasm, all women should need endometrial evaluation. So whom endometrial evaluation is needed, that's we are trying to discuss. Atypical glandular cell favor neoplasm, all women. Atypical glandular cell age more than 35, women more than 35 with the risk factor of endometrial hyperplasia require endometrial evaluation. And benign appearing endometrial cell in premenopausal women with abnormal uterine bleeding and risk for endometrial hyperplasia and postmenopausal women. The reporting of the endometrial cell on pap test is based. Women aged less than 45 do not have endometrial cell is reported on the pap test because this is a common benign finding. Women less than 45 do not have endometrial cell reported on their pap test because this is a common finding, benign finding, particularly if pap test is performed during the first 10 days of the menstrual cycle. In women aged more than 45 is more concerning of the endometrial hyperplasia and cancer. This is high and associated risk factors should be evaluated if there is obesity present or not, if there is abnormal uterine bleeding, postmenopausal, and this risk factor, chronic anovulation, this thing should be uh, take as a concern. Therefore, postmenopausal women with endometrial cell on pap testing require further endometrial biopsy. Patient diagnosed with endometrial cancer typically undergo a hysterectomy with bilateral salpingo-oophorectomy is treatment. Atypical glandular cell AGC on pap testing may be due to either cervical or endometrial adenocarcinoma. All women more than 35 with atypical glandular cell or women less than 35 with atypical glandular cell and risk factor obesity and anovulation require evaluation for endometrial cancer by doing biopsy. Therefore, atypical glandular cell AGC on pap testing is investigated with colposcopy, endocervical curettage, and endometrial biopsy to evaluate the ectocervix, endocervix, and the endometrium. Therefore, AGC on pap testing, AJC on pap testing is investigated with colposcopy, endocervical curettage, endometrial biopsy to evaluate the ectocervix, endocervix, and the endometrium. As a result, return to routine pap screening is not. As a result, return to routine pap screening is not needed. Now, most important, cervical cancer. Cervical cancer, the risk factors are immunocompromise, early onset of sexual activity, multiple or high risk sexual partner, previous STD and tobacco use, HPV 16, 18 are the cause. So, immunocompromise, early onset of sexual activity, multiple high risk sexual partner, previous STD, and tobacco use. These are the risk factor. HPV infection 16 and 18 is the pathogenesis. Clinical manifestation asymptomatic postcoital or intermenstrual bleeding, postcoital or intermenstrual bleeding, increased vaginal discharge, postcoital or intermenstrual bleeding, increased vaginal discharge, pelvic or low back pain, and inguinal lymphadenopathy. Cervical biopsy should be done or on cervical biopsy on colposcopy. Cervical biopsy on colposcopy. This is the risk factor. Another risk factor, infection with HPV, high risk HPV, HPV 16 and 18, immunocompromised, early onset of sexual activity, early onset of sexual activity, multiple high risk sexual partner, immunosuppression, OCP, tobacco use, and low socioeconomic condition. These are the high risk factor. These are the high risk factor for having cervical cancer. This is normal cervix. This is low grade. This is high grade CIN, and this is cervical cancer which invade the basement membrane. Although cervical cancer can be asymptomatic, patient typically have vaginal bleeding after intercourse. Usually after intercourse, there is vaginal bleeding, post-coital bleeding, and due to trauma to the cervix, there is exotic frabble bleeding with manipulation lesion due to tumor growth, painless ulcerative lesion due to tumor necrosis, painless ulcerative lesion due to tumor necrosis, and there is painful inguinal lymphadenopathy can be developed. In advanced stage, metastasis can develop and can cause painless inguinal lymphadenopathy. So, uh, postcoital vaginal bleeding, fibril lesion, fibril bleeding with manipulation due to tumor or painless ulcerative lesion due to tumor necrosis and painless inguinal lymphadenopathy. Cervical biopsy should be done, and which can be performed during pregnancy. Cervical cancer screening, onset of sexual intercourse at the time of diagnosis, annually three or more than three normal results than routine testing. Immunosuppressed SLE or organ transplant, onset of sexual intercourse, annual pap test with HPV co-testing, age less than 21, no screening, age less than 21, no screening, age 21 to 29, cytology every 3 years, cytology every 3 years, cytology every 3 years, and 30 to 65, 30 to 65 cytology every 3 years, or cytology plus HPV testing every 5 years, and primary HPV testing every 5 years. Age less than 21, no screening is needed. 21 to 29, cytology every 3 years. Age 30 to 65, cytology every 3 years, or cytology plus HPV testing every 5 years. Primary HPV testing every 5 years. Age more than 65, no screening if negative. Prior screen or low risk, and hysterectomy, no screening if negative. prior screening, and low risk. Normal PAP results exclude persistent HPV infection and patients with adequate screening by age 65 at low risk of developing cervical cancer. If a patient has a history of cervical intraepithelial neoplasia 2 or higher on histology, screening continues another 20 years after detection, past age of 65 if indicated. Terminating PAP test any age. Uh, Terminating PAP test at age 65 may not be appropriate for women with cervical cancer risk factor like immunosuppression, high risk sexual activity, use of diethylstilbestrol, and tobaccos. After diagnosis, these screening should be done. Age more than 65, usually no screening if negative. Prior screening and low risk cases, no hysterectomy, no screening if negative. Prior screening and low risk. 30 to 64, cytology every 3 years. Cytology plus HPV testing, cytology every year, cytology plus HPV testing every 5 years, primary HPV testing or primary HPV testing every 5 years. Cervicitis, to know in acute cervicitis the organisms are chlamydia and gonorrhea. Treatment is ceftriaxone and azithromycin. Ceftriaxone and azithromycin are empirical. Ovary. In ovarian hyperstimulation syndrome, increased HCG enhances ovarian vascular permeability. Increased HCG enhances ovarian vascular permeability and acute fluid shift to the extravascular space. Acute fluid shift to the extravascular space. Ascites, respiratory distress, hemoconcentration, hypercoagulability, electrolyte imbalance, multi-organ failure or renal failure, DIC, multi-organ failure or renal failure, and DIC. Evaluation is fluid balance, monitoring serial CBC on electrolyte serum ECG, pelvic ultrasound, chest X-ray, and echocardiography. Management, correct electrolyte imbalance, a paracentesis, therapy synthesis, thromboembolism, prophylaxis, correct electrolyte imbalance, paracentesis, orthorhombosis, thromboembolism, prophylaxis. In ovarian hyperstimulation syndrome, OHS is a rare but life-threatening complication of the ovarian inversion. Ovulation triggering agent HCG injection stimulate the artificial maturation of multiple ovarian follicles in patients undergoing infertility treatment and can cause an exaggerated ovarian response, bilateral enlarged cystic ovaries with multiple follicles, as well as overexpression of the vascular endothelial growth factor VEGF, causing increased vascular permeability, increased Doppler flow, and capillary leakage. These causes massive extravascular fluid shift, third specific, and VEGF leakage into the intraperitoneal cavity, leading to ascites and abdominal distension. In ovarian hyperstimulation syndrome, there is ECG increase due to ovarian vascular permeability. There is ascites, respiratory distress, and hemoconcentration is seen. OHS. Hyperstimulation due to HCG, due to hemoconcentration, due to hypercoagulated, due to ascites and respiratory distress. Management, correction of the electrolyte imbalance and paracentesis and thoracocentesis, thromboembolism, prophylaxis. Affected patient develop ovarian hyperstimulation in moderate to or after ovulation. If a patient is having ovulation inducing drug, then this may happen 1 to 2 weeks after ovulation inducing drug. Ovulation inducing. Symptoms include nausea, vomiting, and abdominal pain, and other is pleural effusion, tachycardia, decreased breath sound, intravascular volume depletion, tachycardia, and hemoconcentration leukocytosis due to third spacing, while in severe cases can result in thromboembolism, renal failure, and death. An ectopic pregnancy. An ectopic pregnancy can present with clean abdominal free fluid and a positive beta HCG. However, uh, patients have unilateral adnexal finding, hypervascular mass, and anemia, then a bilateral adnexal cyst and hemoconcentration. The patient's beta HCG level is due to recent HCG injection, not pregnancy. Okay, acute abdominal or pelvic pain in women. Mittelschmerz is recurrent mid or unilateral mid-cycle pain. It's a mid-cycle pain prior to ovulation. Mid-cycle pain prior to ovulation. Pain lasts hours to days, not indicated. Ultrasound not indicated. In ectopic pregnancy, there is amenorrhea, abdominal or pelvic pain, and vaginal bleeding, positive beta HCG, no intrauterine pregnancy. In ectopic pregnancy, there is no intrauterine pregnancy. In ovarian torsion, sudden onset severe unilateral lower abdominal pain, sudden onset severe lower abdominal pain, nausea and vomiting, unilateral tender adnexal mass on examination. Enlarged ovary with decreased and or absent blood flow. Enlarged ovary with decreased or absent blood flow. Rupture ovarian cyst, it's a sudden onset severe unilateral lower abdominal pain, sudden onset severe unilateral lower abdominal pain immediately following strenuous or sexual activity. Sudden onset severe unilateral lower abdominal pain immediately following strenuous or sexual activity. There is pelvic free fluid. Pelvic free fluid is present. NPID, fever chills and vaginal discharge, lower abdominal pain and cervical motion tenderness. There is tubo with or without tubo ovarian abscess. Adnexal masses are common, typically benign in women of the reproductive age. However, patients with a new adnexal mass require assessment for emergency. Gynecological condition like ectopic pregnancy, torsion, or a possible malignancy, epithelial ovarian cancer. Clinical features concerning for malignancy include postmenopausal age, chronic or worsening pelvic pain, and a mass symptom, bloating or constipation. Initial evaluation of adnexal mass is with a pregnancy test. It's a pregnancy test and a pelvic ultrasound. Pregnancy test and a pelvic ultrasound. Pelvic ultrasound visualizes ovarian blood flow, Doppler flow, mass size, and internal mass feature. On ultrasound, malignant masses typically appear complex, solid, and cystic with irregular thickened internal septation or papillary projection. Patients with these adnexal mass findings require further evaluation. In contrast, adnexal mass are common in premenopausal women and may cause symptom, pain and pressure and may be found incidentally on examination. Physiologic corpus luteum cyst reveals a simple appearing ovarian cyst, with a normal Doppler flow. Because physiologic ovarian cysts resolve spontaneously, The best next step in the management is observation and repeat examination in 6 weeks. In premenopausal adnexal mass evaluation, if there is adnexal mass, pregnancy test and pelvic ultrasound done. Rule out if positive, rule out ectopic pregnancy. If negative, malignant feature, yes, surgery. No, conservative management, NSI, narcotics. Repeat ultrasound every 6 weeks until resolution. So, premenopausal adnexal mass, premenopausal adnexal mass evaluation, pregnancy test, and pelvic ultrasound. Rule out ectopic pregnancy. Positive, rule out ectopic. Negative, malignant feature. Yes, surgery. No, conservative management, NSAID or narcotics. And repeat ultrasound every 6 weeks until resolution. This is middle marsh is a mid-cycle pain in a young woman, unilateral abdominal pain in middle of the menstrual cycle, 10 to 14 days, middle of the menstrual cycle, corresponding with the time of the ovulation, middle 10 to 4 corresponding with the time of the ovulation. It's corresponding with the time of the ovulation. Last less than 1 to resolving without intervention. Ovarian cystic rupture, acute onset unilateral pain. It's an acute onset unilateral pain due to cyst rupture and spilling of fluid into the peritoneal cavity. Diagnosis is confirmed by ultrasound, typically simple thin wall cyst and a free fluid in the pelvis. Hemodynamically stable patient are managed with observation and reassurance, and rupture ovarian cyst can cause hemiperitoneum, rigidity, rebound, guarding, referred shoulder pain. Hemodynamically unstable patient with peritoneal signs require emergency surgery. And that's all about the uh, fourth session. This is the fourth part of my video topic. Hope you enjoyed.